let's get underway. I've asked Joe Liddane, who's the chair of the Whittington Hospital, to give his case for what the hospital are planning to do, which has brought so many people here tonight. There will then be time for questions, but please make them sharp and to the point in questions so we get as many people as possible in, and also there will be a second slot for questions a little bit later on in the meeting. So thank you all very much for attending. Thank you to the Whittington for coming along and being prepared to answer questions on this. So Joe, if you could give us your contribution now, please. Joe Liddane, chair of the Whittington Hospital.
Thank you, Jeremy, and thank you more broadly for inviting us here tonight. We take this seriously, so there are 11 of our 13 board members here tonight, all of them ready to answer questions, and I'm clearly speaking on their behalf. Some of them are here at the front facing you, some are on the stage with me, and I thought I would briefly introduce on my far right Anita Charlesworth, who's a non-executive director, Greg Battle, who is a local GP and a joint medical director of the hospital and the community.
Can these people wave or stand up as you give their names, please?
Do you want to stand up, Greg, just so people see? Greg Battle, GP and joint executive director, medical director. On my immediate right is Brona Scott, our chief nursing officer. Over on my left, beyond Jeremy, is Martin Cooper, who is also a medical director, and on the far left is Dr. Yimin Ko, who is our chief executive. The thing to say about us is that most of us are local residents, and therefore the plans that we have made and that we had to discuss tonight matter to us very much personally as well as professionally. One of the key principles in our plan is that we will provide more care for our patients where they need it. And the first thing to make clear really is that these plans are about improving, not downgrading our services. Secondly, you really need to understand that many important aspects of care will continue to be provided in the hospital. Where people's needs are urgent or serious, they will continue to be treated in either A&E, in surgery, or with complex diagnostics, or without having a baby. All of those people in those groups will continue to be treated in the hospital. However, there are many conditions which are often better treated in a local clinic or a health centre or in people's homes. We know that we can now help people to recover much more effectively and quickly, for example, from surgery and other treatments in hospital. We also know that their physical and mental well-being are enhanced by getting them home as soon as we can, with the appropriate support, rather than keeping them in a hospital bed. Decisions to do that, I must stress, are always taken by medical staff and in consultation with patients. The general direction of our plans is because of advances in drugs, technology, or treatment. So some examples. Keyhole surgery, which I think most of us understand. Statins, which lower cholesterol, and treatments where we are able to get people up out of bed and help them to move around early are all in their best interest. So, to be more precise, people with conditions such as diabetes, breathing difficulties, chronic heart problems, or those who, for example, might need physiotherapy, can often be more effectively handled in the community. This usually occurs after an initial hospital treatment. It's also important to say that this idea of care in the community is not something we've dreamt up. It's happening worldwide, and it's increasingly happening across the UK. These advances and these trends are very well understood by the people who oversee the funding of hospitals. Deciding where and how to spend money allocated to healthcare is now firmly in the hands of local GPs. So the overall direction that I've tried to explain is both required by them and our plans agreed or developed in conjunction with them. They are enthusiastic supporters of integrated care, and they keep a close eye on how we implement these plans and how we progress them. These plans clearly have implications for our organisation. Our processes, our systems, technology, our staff and our premises all need re-evaluation in the light of these trends. So we are planning to make better and fuller use of the 33 or so local clinics and health centres that are already out there and delivering this care in the community. Many of these centres already also house GP practices, so I think you can probably see that this allows us to coordinate care locally much better than in the past. We're planning to allocate money that is presently invested in buildings that are either unused, and there are some, underused or not well used, and invest that money in what we consider to be the much needed improvements to other buildings and services. About 4% of the buildings in our plan are presently being used to provide services to patients. All these will be provided elsewhere and mostly in the hospital. You probably know that our plans mean that we will spend £10 million on a much needed upgrade to our maternity. Something we've been talking about for 15 years and have been unable to do while the premises have declined. This upgrade will give us a unit that our community and our staff want and will all be proud of. Without it, we risk falling behind other local hospitals. £2.9 million will be spent on a new same-day treatment centre for urgent care, diagnostics and other routine treatment. This will reduce the need for many patients to stay overnight and will improve the care we can give in our A&E. To do all of this, we need to be a foundation trust because this is the means by which we stay in control of our destiny and our future. We know that we've mishandled the communication of our recent plans, and we apologise for that. This has led a number of people to conclude that we've been secretive about our plans. And this hurts us, this pains us, because it's not correct. We publish all our plans on our website. All of our board meetings are held in public, and I see a number of faces in the audience who regularly come to those public board meetings. We've always sought to be very open about all that we are doing. As I've said, 10 of our 13 board members are local residents. As members of the local community, we have a clear interest in protecting and improving the hospital and all our health services. We want to continue to engage with you as we move forward, so we also will be setting up further public meetings. And we welcome you to those and welcome all the suggestions that you might bring. That's what I want to say on behalf of my colleagues, and we're now happy to take comments and questions either from the front or my colleagues in the front here who will introduce them themselves if necessary when they answer.
Thank you very much, Joe. Now questions. First one over here, gentleman over there.